Hello everyone, my name is Jen Nolan and I'd like to welcome you to the fourth webinar in Move Muscle, Bone and Joint Health's 2017 Musculoskeletal Health webinar series. Tonight's webinar is on the topic of common foot problems experienced by people with musculoskeletal conditions. After tonight's webinar, we will have one more webinar to present in the first half of this year, and that will be coming up in a couple of weeks at the end of June. Details regarding our webinars in the second half of the year will be available soon and will be sent to you. Please also remember that the recordings of previous webinars are also available for purchase at any time. Before introducing our presenter for this evening, I just have a couple of housekeeping issues to run through. Firstly, if you have any technical difficulties during the webinar, please refer to the message box on your screen. You can type a message at any time that will be read by the organiser at Redback Conferencing. If you are listening via the phone, you will notice a small time delay between the audio and the screen. This is normal, so don't be concerned. Also, whilst our presenter will answer questions at the end of her presentation, you can type questions for her at any time. Can I suggest you don't leave your questions to the last minute, as we will aim to finish no later than 8 p.m. Australian Eastern Standard Time. I'd also be very grateful to all participants if you could take a moment during question time to answer our feedback survey. Our presenter for this evening is Professor Deborah Turner, Director of the Academic Program for Podiatry in the School of Science and Health at the University of Western Sydney. Deb graduated as a podiatrist in 1996 and worked as a clinical specialist podiatrist in rheumatology and as a researcher at the University of Leeds. She gained her PhD in 2003, which focused on biomechanical foot function in patients with foot ulceration. In 2007, she gained a prestigious allied health professional academic fellowship through Arthritis Research UK and was also awarded a postgraduate certificate in medical ultrasound in 2009. She's since acted as a tutor and lecturer on musculoskeletal ultrasound courses organised by EULAR. She has undertaken a broad program of research focused on investigating how inflammatory arthritis affects the feet, especially in those with rheumatoid arthritis, psoriatic arthritis, and juvenile idiopathic arthritis, and has published widely in the field. Without further ado, I'll hand proceedings over to Deb. Thanks very much, Deb.
Thanks, Jen, for the kind introduction. And what you'll appreciate this evening aligns to some of my previous expertise is whilst we have quite a broad topic to cover in terms of common foot problems, I will set my stall out and make it clear that there will be focus on patients with inflammatory joint disease, and there will be quite a high emphasis on the utility of ultrasound imaging in managing these problems. So really what I hope to do this evening is to consider some of the manifestations that are part of normal aging. So spend some time talking about the foot in aging. And then really what I wanted to focus on were a couple of key scenarios that really when faced out in clinical practice can be quite challenging. So when presented with the swollen foot, and very much have a discussion around septic arthritis versus gout and how we might be able to, in community-based practice, make some informed decisions. We'll talk about the painful forefoot and again a focus on being on high alert for identification of patients with inflammatory joint disease. And then we'll focus on presentation in the painful rear foot with patients with seronegative arthropathies. So if we think about the effect of aging on the feet, well, really, it can affect all areas of the foot, including the skin and nails, but has a deleterious effect on major soft tissue structures, including muscles, tendons, ligaments, and soft tissues. We can't forget that there is an effect of aging on the arterial and venous systems, nervous system. And then we've got to think about those factors in the presence of disease, namely inflammatory joint diseases. Now, when we consider the foot, it's a really complex anatomical structure. Each foot has 26 bones, there are 33 joints, and more than 150 muscles, tendons, and ligaments. And when we think about the foot, we can really consider it divided up into functional units, including the rear foot, midfoot, and forefoot. In terms of when we're managing problems, we really need to have an adequate understanding of the functional requirements of these individual components. What we need to consider really is that we need optimized function in all of these key areas to be able to achieve efficient and pain-free walking. And given that the average person will walk somewhere in the region of 4 miles a day, we can clearly see that problems in the feet would unduly affect people's ability to undertake normal activities and have a negative impact on their quality of life. If we think here and we think around our functional units, so our forefoot here, we can see that we have anatomically specialized soft tissues, including bursa and fatty pads. And all of these will be affected by the aging process in a deleterious manner. And I'll talk about that in a little bit more detail. But if we can see that we will have, and our metatarsal heads just highlighted here, our hyaline cartilage. We then have our special adaptations of our plantar plate apparatus. Our metatarsal heads are bound together by our intermetatarsal ligament, which we see just highlighted here. And then we can see this complex apparatus of all the intrinsic foot muscles, the flexor apparatus. On the top, we can imagine the dorsal digital expansions. And then between the metatarsal heads, we will have our nerve and arterial supply, where we can have the option where these will get compressed and obviously present in certain manifestations, often related to pain. Now, I've mentioned that we really need to consider the aspects of the foot in terms of key areas of the foot, but the required function as well. And this is quite a simplistic view of foot function, but really we would consider that we have our primary goal of the heel rocker at initial contact or heel strike. And really the structures under the heel are designed to take around 110 to 120% of body weight. What we then need is adequate range of movement at the ankle joint, and we can see just highlighted here that we have our ankle joint rocker here. And we can see that we need an adequate amount of dorsiflexion to be able to take the tibia over the stationary foot to progress the center of gravity over the stationary foot. Then as we get into the final stage where we are looking to achieve efficient propulsion, we need adequate muscle power, predominantly in the posterior compartment of the leg, but we also would need adequate movement at the metatarsal phalangeal joint. And often these structures would need to be pain-free. Often what we tend to find is when people have pain in this area, they will adapt their gait and it will become apropulsive. When we consider the distribution of pressure under the foot, then this is a typical pressure, peak pressure profile that we would see, where we would expect to see a normal maintainment of the medial longitudinal arch. It's likely that we would see quite high pressures represented here. The pinks and the reds are our high pressure areas. We would see this under the heel. This is quite normal and aligned to the initial contact and loading response that we see here in our ground reaction force time curve. But we will often see high pressures, often under the first metatarsal head or just lateral to that under the second. And this aligns to where we have our toe rocker and our second stage of increased loading within our force time curve. And all of this needs to happen in a quite a coordinated manner to have effective pain-free movement. So really, when we consider normal foot function, we consider that people need to be able to walk with the correct timing and spacing, which we often refer to as temporal and spatial parameters of gait. The joints would need to move with sufficient range and in the appropriate direction, and the timing would need to be appropriate. We need to ensure that the muscles would generate sufficient force and joint power to be able to bring the body over the stationary foot. And there needs to be the ability for these forces to be distributed effectively as the pressure profile across the foot. And when we consider age-related changes, we will see distinct changes in all of these areas, resulting in compensations. And we'll talk about that in a little bit more detail in a minute. Sorry, I'm having difficulty just taking that off now. I've got it off. I've got it down. So when we consider ageing, we need to think about what the effect would be on the bones and the joints. And I think we've always got to be cognizant that when we start to deal with patients with inflammatory joint diseases, we need to consider what the age-related changes may well be. So as people tend to get older, particularly postmenopausal females, we will tend to see decreased bone mineral density. Often we would expect to see some joint space narrowing as people tend to get older. They would tend to develop radiological evidence of osteoarthritis within their joints, characterized by joint space narrowing and perhaps loss of articular cartilage. Around the periphery of the joints, as we can see here, with our osteophyte formation around the lateral and medial sides of the joints, and then distinct formation of deformity. Generally, what we would tend to see is that we would tend to see that this will change foot function, often reducing foot function with loss of function, and particularly if we're noting these would be typical foot deformities that we could see as part of the normal aging process. And it's not uncommon to see lesser toe retraction, where the toes will become non-weight bearing. And what we've got to consider is that this will have implications in terms of the pressure distribution under the foot, but also combined with stability and balance. When we consider aging and the effect of muscles and tendons, well, generally as people tend to get older, we expect to see a decrease in muscle mass. And as a result of that, we would tend to see a decrease in muscle strength. Not uncommon with manifestations where people have developed osteoarthritis in the knees, as we can see depicted in this image here in this slide, where we can see that we have evidence of osteoarthritis and resultant pain in the knee. We will often see resultant disuse atrophy in the surrounding muscular structures. What we then have to consider is that this will then have a knock-on effect on the venous system within the lower limb, and it's not uncommon to see venous insufficiency as we see atrophy of the gastrocanthaleus muscles. Often we will tend to see when people have a painful knee joint that they will often develop a flexion deformity, which we can see highlighted in this slide here. Often it's not uncommon to see atrophy of the interossei muscles and digital deformities, as we can see highlighted in this slide here. When we consider the aging effect of soft tissues, generally we would tend to see atrophy of the fat pad, and this is most notable under the metatarsal heads. In combination with lesser toe deformities, often what we will see is not only will the fat pad become atrophied, but it will become displaced as well, and it will be pulled forward anteriorly and often sit around the webbing area. Generally, we need to appreciate that the soft tissues will become less elastic with increased stiffness. When we consider the collagen in our ligaments and tendons, again, they will become less elastic and more stiff, with the likelihood of injury and development of pathology is more likely as people get older. And if we consider just in this image here, just the complex muscle attachments around the medial ankle, it's not uncommon to see tendinopathy in the tibialis posterior tendon, which is a really important tendon in terms of maintaining the stability of the medial longitudinal arch. As we can see an increase in stiffness and mechanical inferiority of the intermetatarsal ligament, it's not uncommon for people as they get older to report that their foot actually gets wider, and we can see this highlighted in this slide here, often accompanied with splaying of the digits. When we tend to consider some of the symptoms that patients will report, well, one of the most common symptoms that patients will report to podiatrists is this sensation of feeling like walking on pebbles. And this is a typical image that we would see of a patient with rheumatoid arthritis, where what we can see is that we've had the formation with subluxed metatarsal phalangeal joints, formation of adventitious bursa underneath, and these really quite distinct and very hard plantar callosities, which are extremely painful. What we will tend to see in these cases, if we were to do plantar pressure measurements, is the formation of very high and focal peak plantar pressures across the site. And what we've got to consider with the lesser toe retraction, like we can see here, is that this is a depiction of the what should be the submetatarsal fatty pad being anterior displaced here. What we will often see in patients with inflammatory joint disease is that we will often, instead of having a nice smooth contour of the metatarsal head, there will often be formation of joint erosions on the plantar surface of the joint. What we see depicted here is we see depicted an ultrasound scan of the soft tissues under the plantar surface of the metatarsal head. And generally what we would tend to see is that this can become exceptionally thin as people get older, but particularly in conjunction with lesser toe deformity, where often you may see less than a couple of millimeters of fatty padding. And this is the typical, you'll see that this is a slide where we can see that there's a significant reduction in the integrity and the quality and the thickness of the soft tissue here. And I think that it's really important when we're considering the management aspects is to actually listen to the patients in terms of the sensations that they're complaining of. What we see highlighted in this slide here is we see an example of a patient that came into our clinic that actually had an isolated subluxed metatarsal head. And what you can see that the patient has actually attempted to do is they have attempted to deflect this subluxed metatarsal head and allow it to sit in a very cushioned environment. So this was quite thick Axminster carpet, providing a real cushioned area for under the foot, but recognizing the need to offload a high pressure area. What we can see is this is a picture again of how a patient has tried to self-manage their foot problems. So this is actually a patient with rheumatoid arthritis who, as you can see, has quite advanced forefoot pathologies, but also midfoot complete collapse of the medial longitudinal arch. But the patient has recognized the need to really well cushion the plantar surface of the foot and particularly these high focal areas. And this was a combination of a spongy cushioning material, but also with some sheepskin lining. And this is what the patient, when they came to see us on the first occasion, had actually been managing with for about 3 to 4 years. So it's important in terms of speaking with the patients and actually kind of working with them in terms of working out what might be effective, because it generally tends to increase patients' compliance with orthotic devices. I think we've also got to bear in mind that whilst we might consider the manifestations in the musculoskeletal system, we've got to consider the knock-on effect as well on the venous system. And there's high prevalence of venous problems in patients with rheumatoid arthritis and inflammatory joint diseases, and often related to the fact that we will see atrophy of the gastrocancelleus muscles, which we've got to recognise have a really important role in helping with venous return. What we've got to also consider is often we will see problems in patients with benign joint hypermobility, where we have differences in the integrity of the collagen, and it's not uncommon to see really quite pronounced varicosities in patients with benign joint hypermobility. who may often also have problems with their knees in terms of recurrent patellofemoral subluxations and dislocations. We've also got to consider that one of our important structures as well is the skin, and recognise the importance that the skin has, particularly in the foot. It's a really important organ in terms of helping to dissipate some force, but also in terms of a protective barrier against environmental agents and bacterial and viral and fungal manifestations. And generally, as people tend to get older, we will tend to see thinning of the skin. There will tend to be a lower oil secretion, making the skin drier and more itchy. And you can see in this image here that this is the typical type of heel that we will see, where we will see the formation of really, really dry skin kind of around the heels. Often, I think, in Australia, where there's a high proportion of patients wearing open back sandals, for example, I think that this makes this manifestation far worse. And what we've got to consider is that the functional requirements of the heel will be to allow kind of expansion of the soft tissue under the heel on heel strike. When the skin is so rigid and is inflexible, the fat pad has the inability to stretch, and very often you will tend to find the formation of fissuring around this key area. What we will often see as well is it's not uncommon for people to develop pigmentation changes, so the formation of hematidrosis around the medial malleolus is very, very common, associated with the deposition and degradation of the red blood cells and subsequent stasis. What we will often find is that that can often cause localized irritation. The patient will then scratch that, and then we will get secondary excoriated areas which may well have the potential to become infected. Generally, the skin will become reduced in its strength and its ability to withstand the normal forces as people get older, particularly if that's in combination with some medications, particularly steroids. And there's generally a reduction in elasticity as people get older. So effectively, a reduction in the foot's ability to withstand some of the normal forces that we would expect to see during normal walking cycle. In terms of some of the effects that we will see on the nails, resulting, it's not uncommon for people to develop a generalized thickening of the nails as they tend to get older. What that tends to do is make the nails quite difficult to cut, and it's not uncommon to see cases where people have struggled, the nails get quite unmanageable, and unfortunately it's still very common that we will see cases of neglect, as I'm highlighting at the bottom here. When we tend to see the thickening of the nails, often we will find that patients will report pain under the nail matrix, and it can become self-perpetuating in the fact that as the nail becomes thicker, there's more trauma on the underlying nail bed, and it becomes a cyclical process where the nail just becomes resultively thicker. What we've got to be aware of is that if we do have constant pressure of the nail on the subungual tissues, that there is the risk that people can develop an ulcer or a corn actually under the nail. It's not uncommon as well that as the nails become kind of deformed, particularly curved like this, that patients can develop an ingrowing toenail, as we can see here. What we've got to consider again in patients with inflammatory joint disease that might be on immunosuppressant drugs, that there is a high chance that they may well become infected. And these would be prime candidates to consider for a total nail avulsion to remove the nail and use a chemical to stop that coming back. So in summary, in terms of considering the age-related changes, we've got to really consider the impact that aging will have on all of these structures, and then consider the disease-related changes on top of those. So the next area that I really wanted to talk about was when you are faced in clinical practice with presentation of a hot swollen joint. And one of the key areas is, one of the key questions is this active gout? But we really do need to consider that really this could be septic, and really the advice is that we should consider these joints to be septic until proven otherwise. So really, what is the best practice guidance out there when we're faced with this in clinical practice, and how can we adapt that best practice when working particularly in community settings? Well, the clinical dilemma really of this swollen joint really is that we need to think about how we can try and determine whether it is indeed septic arthritis. And we've got to therefore be aware of the associated risk factors with septic arthritis. We've got to consider, particularly in managing our patients with inflammatory joint disease, the area of biologic drug therapies and the immunosuppression and the increased risk of septic arthritis. And we've got to be really aware of being able to, with confidence, to be able to perhaps be able to determine whether we think that this is gout, or perhaps whether we do actually think it could be a septic arthritis. Now, generally, why are we really concerned about the presentation of an acute monoarthritis? Well, it can be a whole number, a spectrum of different aspects, but really with septic arthritis, this can be potentially life-threatening. And certainly the earlier identification of a septic arthritis really will improve patient outcome. So when we consider a septic arthritis, what is it? Well, it's bacterial invasion into a synovial space. And whilst it's relatively rare, we do need to have it on our list of differentials and be quite confident in being able to detect it. What we've got to consider is that when we look at the yearly incidence, when we consider the incidence in patients with rheumatoid arthritis, and particularly those with prosthetic joints, then the incidence does increase quite significantly. It is associated with significant mortality, and certainly the research suggests that the in-hospital mortality figures can be as high as 15%. We do want to be able to identify it early and to obviously be able to improve patient outcome. So in terms of what the clinical signs would be, well, an acute presentation of joint pain, associated swelling and warmth around the joint, erythema around the joint, and associated fever with a temperature greater than 38.5 degrees Celsius. Often the patients will present with a general presentation of malaise. But what we've got to recognise is in those patients that will be most at risk of this, and that the features that I've previously just mentioned can be quite subtle in immunocompromised patients. Generally, there would be an increase in their CRP and ESR, but we've got to consider that in patients with an inflammatory joint disease, it may well be raised because of the presence of the inflammatory joint disease. Now, the most common site for a septic arthritis is the knee, and it's around in 50% of cases. But what we've got to consider is when we look at other populations which are likely to have foot problems, diabetes and rheumatoid arthritis, presentation in the foot is far most common. Now, the reason why we tend to have this predilection of sepsis within the joint is because bacteria can easily get into the joint spaces through the synovial fluid, because synovial tissue lacks a basement membrane, which means that infection from other parts of the body through hematogous thread can lodge within the joint. And this slide here really shows the key areas where we would consider the potential routes of infection. So direct trauma and insect bite. If a patient has reported a previous joint or soft tissue steroid injection, for example. we have a previous history of osteomyelitis, if we have extra-articular involvement of other structures around the joint. And it's really important that we do consider some of these other factors in terms of recent travel, recent illness, particularly asking about insect bites. Now, the hand's the most common site for septic arthritis, and it's the third metacarpophalangeal joint. But just must be more a prominent area for insects to actually bite. Whilst we don't have the same distinct relationship in the foot, it should be part of our questioning in terms of when someone presents with an acute swollen joint. We've got to consider also some of the other factors. What we have here is a slide where we've had a formation of an adventitious bursa, where the occupation relies a lot of kneeling. So we can see that we've had the formation of an adventitious bursa here over the body of the talus with a small break in integrity, with a connection right kind of into the ankle joint area. So when a patient presents with something like this, then we do need to be on high alert for the potential of a septic arthritis. So in terms of what we know about the predisposing factors, well, there has been a systematic review which has looked at the literature and looked at determining the likelihood ratios. And generally, I think one of the key areas that we need to consider is where we see our highest likelihood ratio of 15 in those that have a prosthetic joint with an overlying infection of the skin. That our potential likelihood ratio is very, very high of a potential septic arthritis. But we also need to consider our other kind of areas that are highly likely in patients with inflammatory joint disease, for example, intra-articular joint injections. So in terms of our predisposing factors, so we have considerations in terms of those with diabetes, rheumatoid arthritis being found to be twice as high in males, and in terms of our previous intra-articular joint injections, with the time span from the previous injection being as much as 24 weeks in some cases. So it doesn't have to be overly recent. What we've also got to consider is the likelihood in patients with HIV or transplant, which are immunocompromised, with the potential being much higher. And in terms of why are patients with rheumatoid arthritis predisposed to septic arthritis, well, if we have a look at this image here, what we can see is this is a normal metatarsal head, where we can see the smooth outline of the metatarsal head and the cartilage. This is a metatarsal phalangeal joint in a patient with RA, and we can see quite clearly that we can see an absence of a normal metatarsal head with quite irregular joint surfaces with lots of potential areas for bacteria to lodge. And if we imagine really that in these areas where we would have joint erosion, there is the potential for microorganisms to hide, for want of a better word, in all of the nooks and crannies and escape the normal phagocytosis that would be ongoing within the joint. What we've also got to consider as part of the inflammatory process, and what we're looking at here, is we're looking at an ultrasound scan of a patient, a metatarsal head. We can see a distinct erosion here, so bone irregularity. This black area here is thickening of the joint capsule, and we can see the presence of a power Doppler signal. This power Doppler signal is representing new blood vessel formation, so angiogenesis, combined with vasodilation associated with inflammation, which really does facilitate the hematogenous spread of the infection into the synovial cavities. We also need to consider, in terms of sepsis, just the increased use of biologic drug therapies, particularly in patients with rheumatoid arthritis, but increasingly so in patients with spondyloarthropathies. And certainly systematic reviews suggest that the risk of serious infections for patients that are on those drugs, and with effectively a doubling of the risk of a septic arthritis in patients on a biologic drug therapy compared to those without. So we need to consider that as a potential clinical red flag. So in terms of the predisposing factors, then really we do need to be thinking around skin infection, particularly over a prosthetic joint, and the increase in the likelihood ratio. But we do need to also consider, just in terms of the history of physical examination, that sometimes they can give false positives and false negatives in terms of the presence of a septic arthritis. So really the only real rule in terms of being able to rule out a septic arthritis is through an atherocentesis and a synovial culture, which very often isn't practical within a community-based setting. So when we look at the clinical guidelines, it really is along the lines of septic until proven otherwise, and that really the only way that you can get your definitive diagnosis is through synovial kind of fluid aspiration and subsequent culture. So the guidelines really would suggest that really we treat these as septic until proven otherwise, and it's only when we have a definitive alternative diagnosis along the lines of an inflammatory arthritis or crystal arthropathy that really we should be looking to kind of make arrangements for aspiration and other investigations to determine whether there is indeed presence of a septic arthritis. But what we do know is that generally there is poor adherence to the guidelines for the early management of an acute hot swollen joint. And I think the question really to ask is, where would we stand legally if we miss a septic arthritis and we fail to recognise the practice guidelines? So in terms of a septic arthritis versus acute gout, which is probably what we're most likely to see in the foot, it's really important that we have something in our armoury to be able to perhaps guide us in terms of whether we think it is more likely to be gout or indeed a septic arthritis. And there's been a recent study that certainly will help us in the clinical setting in terms of perhaps being able to determine gout versus septic arthritis. Now, the scoring system will work on assigning a score related to the presence of these factors. So you can see along the line here that if someone is male or they've had a previous reported arthritis attack, that they would get a score of 2. Looking at these, as you can see, as you work your way down, that generally the probability of gout would be, if someone is scoring 8 or more, that the probability of gout is high. Whereas if they're scoring below 4, then the probability that it is gout is low. And conversely, that really we need to be then considering that this is more likely to be septic arthritis. And in terms of this study, what we can see is using the items for the scoring, that certainly there appears to be significant differences between these groups that were subsequently tracked and found to have a confirmation of gout or septic arthritis. Mouse just seems to stop working for a minute. So we can see that when they've actually done their inferential statistics on here, that indeed we can see that there were statistically significant differences in the areas highlighted in the table here. So really what they're suggesting is that by using this, this scoring system that could easily be utilised within community practice, that if indeed their score is suggestive that it's gout, that there is indeed this high probability that it is gout. If it's suggested that it's a low probability of gout, then we can see that there's the potentially high probability that it is indeed a septic arthritis. Whereas if there is the intermediate probability, then really the clinical management needs to be septic until proven otherwise. And in terms of the clinical red flags, really that we need to be consider the real risk or excluding the possibility of septic arthritis in these high-risk groups, including rheumatoid arthritis, diabetes, patients with HIV, joint replacements, and those that have had joint injections in the last 6 months. But certainly my guidance would be to always have your clinical notes reflecting the fact that you have considered a septic arthritis, excluded, and made the appropriate referral or follow-up. Now, moving on to the painful forefoot area, there's a whole manner of things that really could be considered in terms of the presentations. And when we look at looking at the painful forefoot, generally what we tend to know is that a clinical examination can really be lack sensitivity in terms of pathological specificity in terms of what's actually going on. And by using imaging like ultrasound, that we really can increase our clinical confidence of what structures are involved and more appropriately manage these patients. The one thing really to consider in the painful forefoot is, does your patient have the S factor? And this was a national campaign in the UK supported through Arthritis Research UK and NRAS, and really on the basis of, do you have stiffness for more than 30 minutes? Do you have swelling in one or more joints, particularly hands? And is there a positive finding on a lateral squeeze of the MCP joints or the MCP joints, as you can see depicted in the slide here? And that really we do need to be considering early referral for suspicion of rheumatoid arthritis. And the algorithm presented by the rheumatology team at Leeds suggests that if you have a patient with 3 or more swollen joints, a positive MCP or MCP squeeze test, and reporting early morning stiffness greater than 30 minutes or greater, that they should be referred with a high clinical suspicion of rheumatoid arthritis. And when we consider the utility of ultrasound in terms of assessing the joints, my kind of recommendation would be really in terms of trying to better identify patients with suspicion of early inflammatory joint disease, or being able to better determine what the location of pain actually is that ultrasound can really be a useful tool in terms of being able to identify fluid within the joint, whether we have thickening of the synovial kind of joint capsule, or whether we indeed see changes to the bone cortex. And what we've got to recognise is that ultrasound can show bony changes much earlier than X-ray. And it's useful to be able to combine this imaging technique with other modalities, for example, pressure measurement. And what we can see in this slide here is that we have a patient with a high focal area under the 5th metatarsal head, very much higher, although clinically not really looking subluxed, and certainly didn't have an overlying callus. When we looked at it on ultrasound, what we could actually see is that we have the presence of a joint erosion, which we can see, I'm just highlighting here, but that we also have the formation of an adventitious submetatarsal bursa. So ultrasound can really provide some great information in terms of what may actually be going on and what lies beneath, which certainly can influence your options in terms of management. And in terms of the management, then really we do need to be considering the usefulness of different types of orthotics, and certainly dependent on the amount of movement that we have in the foot and whether we have any involvement of the rear foot in terms of deformity, then we might want to choose to use some orthotics that we would class as being functional, where they're quite rigid, And in terms of reducing pain in the forefoot, we really do aim to increase the contact area of the foot by supporting the medial longitudinal arch. In cases where we might not necessarily have a sufficient range of movement, then we might want to try and increase the contact area of the foot with a less rigid and more cushioning device. And this really, in terms of being able to identify patients early, is highlighted in this case here, where we had a young patient with rheumatoid arthritis less than 6 months that was really being adequately managed with her pharmacological medication. And what we can see in this slide here is that she presented with quite a marked deformity in the left foot. We can see that the arch is markedly lower, and that we have the calcaneus in a much more everted position. What the patient actually presented with was persistent synovitis at the posterior tibial tendon. And what we can see in this image here is we can see that on pressure measurements that we can actually see that this patient has started to concerningly bear weight around the medial midfoot, around the navicular area. Suggesting that we're starting to see subluxations at these joints. What we aim to do with this patient was to get her into a rigid orthotic to correct the rear foot position, rest the posterior tibial tendon, and support the medial longitudinal arch. So considering the orthotic as a splint to really support the integrity of the talonavicular joint. And really what we want to be considering in terms of capturing these patients is effectively being able to capture patients where they have minimal rear foot but correctable deformity at an early stage to prevent this end stage typical deformity that we see, where we have a progressive valgus heel deformity that becomes fixed and no longer correctable. In terms of the midfoot, what we will typically tend to see in progressive inflammatory joint disease is a collapse of the medial longitudinal arch. And again, we would want to get in at the early stage with rigid supportive devices to splint the integrity of the medial column and hopefully prevent the progressive collapse of the arch. So in terms of when trying to make a decision in terms of when to refer patients with inflammatory joint disease, clinical red flags really would be around pre-existing foot deformities, particularly tenosynovitis of tibialis posterior. But if you're seeing poor alignment of the rear foot and particularly lowering of the medial arch profile, we also need to consider if we're looking at the context of residual foot problems when we have optimized pharmacological management. Now, I'm aware of our time, but the final aspect really is about considering spondyloarthropathies, particularly in the typical presentation of rear foot disease. So imagine our young rugby player with persistent Achilles tendon problems, has had previous physiotherapy, previous orthotics given by a podiatrist. But if this was a patient that had come to you with poor response to these, would you be asking questions about recent infections? Would you ask if the patient has had diarrhea within 1 month of the onset of symptoms? Would you ask about coexistent eye involvement? Would you ask about any skin involvement? And would you take time to examine the nails? And really we need to be considering this in terms of a clinical suspicion for a spondyloarthropathy. So really what we need to be considering is that for a classification for high suspicion of a spondyloarthropathy is if someone is scoring 6 or more from this table here. And you can certainly see the presence of heel pain, but combined with perhaps skin involvement, psoriasis or inflammatory bowel disease, diarrhea within a month of the onset of symptoms. What we also need to consider, which generally people are quite poor at picking up in clinical practice, is the presence of psoriatic arthritis. And in terms of looking at these, 3 or more, if you have someone presenting with what appears to be articular disease or enthesitis combined with a family history of psoriasis, nail dystrophy, dactylitis. And what we've got to consider is psoriasis is often quite tricky to find and likes to lodge in places that are quite tricky to find, as highlighted here. So you really do need to work carefully in terms of your questioning of your patients. Some of the nail changes may well be quite subtle, as we can see highlighted here in terms of the nail pitting. And particularly in the foot, it can be difficult to determine this as opposed to trauma from sporting activities or fungal infections. So really we do need to be thinking much more in our clinical practice about screening for psoriatic arthritis, particularly in patients with psoriasis. And there are some great resources out there in terms of tools that can be out there, and these can be downloaded outside in through AbbVie, which are nice posters that you can have in your clinic that would allow you to go through some of the screening tools that are out there in terms of determination of psoriatic arthritis. You can see this highlighted here, takes you through step by step how you will be able to go through and undertake some screening. What we've got to consider with the Achilles tendon is we would have the Achilles tendon as being a normal kind of uniform thickness right the way from its insertion up to the musculotendinous junction. But very often what we will see, as highlighted in this slide, is mid-portion Achilles tendinopathy. What we will often tend to see in our patients with spondyloarthropathies is possibly mid-portion Achilles tendinopathy, but also combined with enthesitis. And this is depicted in this slide here, where we can see distinct thickening of the tendon at the insertion here. So this is the Achilles tendon inserting in here. But what we can also see is that we're beginning to see irregularities at the back of the calcaneus. What we will often tend to see as well is that we will see distinct involvement of the retrocalcaneal bursa, which we can see highlighted here in this slide as this distinct fluid-filled area just sitting behind the Achilles tendon. And the reason why we want to identify these patients very, very early is that we want to stop the progression of erosive bony changes, which we can see identified here. And in this particular case, patient, this was actually a patient with a reactive arthritis who developed Achilles tendon after a holiday, developing sickness and diarrhea. And this was the extent of the erosive change within 8 weeks. From initial onset. So this is really why we do want to kind of get to these patients very, very early. In terms of plantar fasciitis, this is often a hallmark area as well, where patients will present with plantar fasciitis and then eventually end up with it will be the first presenting feature of a spondyloarthropathy, which is often missed in clinical practice. And again, ultrasound is really useful at identifying distinct thickening, particularly at the insertion. And what we will often be able to do is compare the thickness of one plantar fascia, particularly a unilateral presentation, to the thickness on the contralateral limb. What we've also got to recognise is that we will often get involvement of the lateral tendons. Particularly watch out for the insertion of peroneus brevis at the base of the fist and examine this area quite well. And generally what we tend to see in our patients with psoriatic arthritis is that we will quite early on in the disease process start to see these distinct changes where we will start to see this focal loading of pressure in the lateral column. And we suspect it's where we start to see subluxation of the calcaneocuboid joint. So really in terms of our management goals, we really need to be good at identifying these patients in clinical practice with really the mantra of zero tolerance of active foot disease and active inflammation. We need to be looking at assessing these patients really well, using imaging where appropriate, with a view to identifying residual disease in the foot. Particularly in the UK, as part of allied health practice with podiatrists and physios, we would look to very much target sites of active inflammation with intra-articular or soft tissue steroid injections, and do this in combination with addressing abnormal biomechanics. And this is the typical approach that we would tend to use in patients with spondyloarthropathies, where we would look to try and control inflammation with arthropathies, where we would look to try and control inflammation with both the pharmacological management, but with local steroids, combined with then optimizing foot function and gait retraining, with a view to trying to be quite aggressive at switching that active inflammation off. So I'm aware that I've gone over time. I'm really sorry. Not going to be much time for questions, but really the foot and ankle is a common initial presentation site for inflammatory joint diseases, and I would urge everyone that comes across patients to always consider this in your diagnostic workup, because early intervention really does improve patient prognosis. And we need to consider really that multifaceted approach where we aim to suppress active disease, but also optimize foot biomechanics. So I'm sorry, I've only just finished. Sorry, Jen.
No, Deb, that's no trouble at all. It was such an incredibly comprehensive and detailed presentation. It's not surprising that you went a bit longer than expected, so that's no problem at all. Thank you so much.
Okay.
If anyone has any questions for Deb, could you please type them in now? At this stage, there aren't any questions that have come through, which is not surprising, Deb, because you've just covered things so sort of comprehensively and thoroughly. So unless anyone's typing in a question now, I mean, I guess the sort of key points I certainly thought were very important tonight was, you know, an initial point you made about listening to the patient, and also just the incredible importance of trying to pick up these signs and symptoms early on to avoid that progression of disease.
Absolutely. Unfortunately, I've heard too many times that when you ask patients where they've had a diagnosis of their joint disease, they will say, well, I got my diagnosis 2 years ago, but I've had my symptoms for, 8 years, and their first symptoms were in my feet, but nobody kind of listened to me and took time to investigate it.
I think that's so true. I just, maybe a person's feet are just sort of not quite considered, and obviously they're just so important with regards to that early identification and early management to avoid, the sort of the more deleterious effects, as you say. So thank you so much for an incredibly interesting and important presentation. It will certainly be on our website and sent out to people who weren't able to watch the screening tonight, and also be available for other people. So thanks very much. And I would ask participants to complete our survey as we finish up tonight. Deb, many thanks again, and thanks to everyone joining in tonight, and also just remind you about our webinar that's coming up at the end of June on the pain management for patients with inflammatory arthritis. So on that note, thanks again, Deb, and thanks to everyone joining the webinar this evening, and good night.
Good night.